Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 161 of our pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, which of the patients described in the case scenarios below is at greatest risk of CMV infection? Is it A, a 52-year-old woman with a renal transplant 8 months earlier who is being treated for acute cellular rejection with high-dose methylprednisolone, CMV donor positive and recipient negative, not taking antiviral drugs, or B, a 31-year-old man with a renal transplant 1 month earlier who is being treated for acute cellular rejection with high-dose methylprednisolone, CMV donor positive and recipient positive, taking valganciclovir? Or, C, a 43-year-old man with a liver transplant 1 week earlier who develops post-surgical bleeding complications and biliary leak, CMV donor negative and recipient negative, taking acyclovir? Or, D, a 32-year-old woman with a renal transplant 13 years earlier who has stable renal function and no recent complications, CMV donor positive and recipient negative, not taking antiviral drugs? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A, a 52-year-old woman with a renal transplant 8 months earlier who is being treated for acute cellular rejection with high-dose methylprednisolone, CMV donor positive and recipient negative, not taking antiviral drugs. The patient in answer B is at low risk of CMV infection or reactivation because of donor and recipient CMV seronegativity. That makes answer C incorrect. The patient in answer B is at moderate risk of CMV infection, but given his current receipt of valganciclovir, CMV infection is unlikely. That makes answer B incorrect. The greatest risk of CMV infection in solid organ transplant (SOT) is in CMV seronegative recipients who receive an organ from a CMV seropositive donor. Even considering the CMV mismatch for the patient in answer D, CMV infection is less likely to occur 13 years after transplantation, given the patient's stable allograft function and lack of recent complications, i.e., treatment of rejection. That makes answer D incorrect. The patient in answer A has just received treatment for rejection, has a CMV mismatch, and is not currently receiving antiviral prophylaxis, which makes answer A correct. Please progress to the next question. And the next question reads, CNA, a 46-year-old male patient is being admitted for a living-related renal transplant tomorrow morning in 24 hours' time. His herpes virus serologies include HSV seronegative, VZV seropositive, EBV seropositive, CMV seropositive. The donor's herpes virus serologies include HSV seropositive, VZV seronegative, EBV seropositive, CMV seronegative. So my question to you is, which of the following would be the most appropriate antiviral prophylaxis for CNA? Would it be A. Valganciclovir for 90 days, or B. Valganciclovir for 30 days, or C. Acyclovir for 90 days, or would it be D. Acyclovir for 30 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Valganciclovir for 90 days. The patient in this scenario is at moderate risk of developing CMV infection, given his own seropositivity. Despite donor seronegativity, the patient is at risk of CMV reactivation. The options for CMV prophylaxis include antiviral prophylaxis for 3 months with valganciclovir, ganciclovir via oral or intravenous route, or valacyclovir or preemptive therapy with weekly monitoring of CMV PCR for 3 months post-solid organ transplant, and subsequent treatment of positive test with valganciclovir 900 mg orally twice daily or ganciclovir 5 mg per kilogram intravenously twice daily until there is a negative test. As such, valganciclovir for 3 months is most appropriate for this patient of the listed options. That makes answer A correct. Valganciclovir for 1 month is an insufficient duration. That makes answer B incorrect, and acyclovir prophylaxis for 1 month is given to patients with CMV at low risk, e.g., in a case of a CMV donor negative, recipient negative of HSV prophylaxis if the donor and/or the recipient is HSV positive, which makes answers D and C incorrect. Please progress to the next slide. And the next question reads, JWA, a 57-year-old female patient is admitted for a cord blood allogeneic HCT at your hospital. JWA is CMV seropositive while her donor is CMV seronegative. So my question to you is, which of the following regimens would be the best for antiviral prophylaxis in this patient? Would it be A. preemptive therapy for 6 months, or B. valacyclovir for 30 days, or C. acyclovir for 6 months, or would it be D. acyclovir for 30 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. preemptive therapy for 6 months. The risk of CMV reactivation is highest in HCTRs, with CMV seropositive status before transplantation. Acyclovir and valacyclovir have been studied for CMV prophylaxis in HCTRs, with varying degrees of success because of their limited CMV-specific activity. As such, neither agent is recommended for routine primary CMV prophylaxis in this high-risk population. That makes answers B to D incorrect. Ganciclovir and valganciclovir have superior anti-CMV activity, but their routine use for prophylaxis is limited by bone marrow suppression. Given this information, preemptive therapy for 1 to 6 months post-allogeneic HCT is recommended. That makes answer A correct. Preemptive therapy includes at least twice-weekly monitoring of CMV PCR for donor or recipient CMV seropositive cases and for patients being treated for graft versus host disease, GVHD. If a test is positive, definition of positive varies by institution. Treatment with oral valganciclovir or intravenous ganciclovir is initiated for at least 2 weeks or until CMV is no longer detected. Please advance to the next question. And the next question reads, STV, is a 45-year-old female patient with HIV infection who runs a day care out of her home. Her current regimen includes abacavir, lamivudine and dolutegravir. Her CD4+ cell count 402 cells per millimeter cubed. She has undetectable viral load, and has no known drug or food allergies. One of the children in her day care was diagnosed with influenza A. So my question to you is, which of the following would be the optimal prophylaxis for STV now? Would it be A. Rimantadine 200 mg orally once daily for the duration of the influenza season, or B. Oseltamivir 75 mg orally once daily for the duration of the influenza season, or C. IIV and oseltamivir 75 mg orally once daily for 14 days, or would it be D. IIV? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. IIV and oseltamivir 75 mg orally once daily for 14 days. The influenza vaccine is the best means of prophylaxis, which is recommended for this patient. However, until she has full immunity from the vaccine, antiviral prophylaxis with oseltamivir or zanamivir is recommended. That makes answer C correct and answer D incorrect. Alternatively, oseltamivir or zanamivir could be used as prophylaxis for the duration of the influenza season. We can give for 7 days beyond the most recent exposure, but the vaccine is preferred for patients without vaccine contraindications. That makes answer B incorrect. Adamantanes only have activity against influenza A, but they are currently not recommended for influenza because of widespread resistance, which makes answer A incorrect. Please advance to the next question. And the next question reads, LTK, is a 54-year-old male patient in the clinic, who presents with a low-grade fever, with a body temperature of 38.2 degrees Celsius and hematuria. His liver function tests are elevated, and he reports increasing cough and shortness of breath over the past week. He has a past medical history significant for the fact that he underwent an allogeneic HCT for AML half a year ago. 21 days ago, he was initiated on methylprednisolone 1 mg per kilogram IV twice daily. He currently receives a prednisone taper at 20 mg orally twice daily. He has no known drug or food allergies. His current anti-infectives include valganciclovir, cotrimoxazole and posaconazole. The hematologist wants to give him a one-time dose of cidofovir 350 mg IV. So my question to you is, which of the following best represents the pathogen that the hematologist is empirically targeting in this clinical scenario? Is it A. BK virus, or B. adenovirus, or C. influenza, or is it D. RSV? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Adenovirus. The patient's hematuria, elevated liver transaminases, and worsening oxygenation, as well as the choice of cidofovir as empiric antiviral therapy, suggest a working diagnosis of disseminated adenoviral infection. That makes answer B correct. BK virus, also treated by cidofovir, is another common cause of hemorrhagic cystitis in HCTRs, but BK reactivation does not result in respiratory symptoms. In addition, primary infection or reactivation does not cause transaminitis. That makes answer A incorrect. Neither RSV nor influenza virus results in hematuria, though both can cause upper and lower respiratory tract infections. That makes answers D and C incorrect. Please proceed to the next question. And the next question reads, KCJ, a 35-year-old female patient recently underwent a kidney and pancreas transplant with enteric drainage for type 1 diabetes mellitus. Perioperative prophylaxis was done using piperacillin, tazobactam for 24 hours, fluconazole for 7 days. 10 days post-operatively KCJ develops a fever, with a body temperature of 38.8 degrees Celsius, and a WBC 21.4 times 10 power 3 cells per millimeter cubed. She has a blood pressure of 85 systolic and 50 diastolic. Blood cultures are obtained, and IV fluids are given, as a one-time doses of piperacillin, tazobactam 4.5 grams and vancomycin 1000 mg IV. The transplant surgeon asks your opinion for empiric antifungal coverage. So my question to you is, which of the following would be the best regimen for KCJ now? Would it be A. Amphotericin B lipid complex 3 mg per kilogram IV once daily, or B. Posaconazole tablet 300 mg orally once daily for 24 hours, then 300 mg orally once daily, or C. Caspofungin 70 mg stat, then 50 mg IV once daily, or would it be D. Fluconazole 800 mg stat, then 400 mg IV once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Caspofungin 70 mg stat, then 50 mg IV once daily. This patient is at risk of invasive candidiasis because of her recent intra-abdominal transplant surgery, receipt of antibiotics for surgical prophylaxis, use of IV catheters, and induction immunosuppression. For initial empiric treatment of invasive candidiasis, the guidelines recommend any echinocandin as first-line therapy. Fluconazole is an alternative to an echinocandin for patients who are not critically ill and are unlikely to have fluconazole-resistant Candida species. This patient is at risk of developing resistant Candida species, especially given that this infection developed while she was receiving fluconazole therapy. Regardless, the guidelines recommend first-line therapy with an echinocandin over fluconazole. That makes answer C correct and answer D incorrect. Posaconazole and amphotericin B are not recommended for initial treatment of invasive candidiasis. That makes answers B and A incorrect. Please move on to the next question. And the next question reads, 72 hours later, KCJ's blood cultures show Candida glabrata, and susceptibility tests later show fluconazole resistance with an MIC of 256 mg per liter but susceptibility to echinocandins and amphotericin B. Repeat blood cultures are negative for fungal growth. So my question to you is, which of the following would be the drug of choice in this clinical scenario? Would it be A. Amphotericin B lipid complex 3 mg per kilogram IV once daily, or B. Posaconazole tablet 300 mg orally twice daily for 24 hours, then 300 mg orally once daily, or C. Caspofungin 50 mg IV once daily, or would it be D. Fluconazole 800 mg orally or IV once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Caspofungin 50 mg IV once daily. This patient's Candida glabrata isolate is fluconazole resistant but susceptible to amphotericin B and the echinocandins. That makes answer D incorrect. Of importance, susceptibility has not been determined for the newer azoles such as voriconazole and posaconazole, and given the substantial degree of cross-resistance with fluconazole in Candida glabrata, neither agent should be used in this setting unless susceptibility has been confirmed. That makes answer B incorrect. Caspofungin and amphotericin B are both reasonable because of susceptibility results, but because of the improved tolerability of the echinocandins, caspofungin is preferred, which makes answer C correct and answer A incorrect. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 162.